in the been in the VMR space, so really excited to see everyone again for another WDx VMR. Maybe while we're having people join in, I will just get us started just talking a little bit about the WDx space and kind of what our mission is here. So as you all know, VMR is a safe space, a community where we get to learn together, talk through a clinical unknown together. And it's been such a wonderful community. And specifically, we like to do a WDx every once a month where we focus on kind of elevating women in medicine and specifically those voices. Recognizing that often everyone, faces imposter syndrome, and some data shows that women in particular sort of battle with this voice in our heads around, do I participate? Do I not participate? And so we're here to have a dedicated, protected space where we can celebrate women in medicine and elevate our voices. So we're really, really honored to have some amazing discussants and people who are going to be showcasing their talent today and learning together. So maybe I'll turn it over to Anika to introduce yourself, and maybe if you wouldn't mind sharing a little bit about kind of what being a woman in medicine means to you, and perhaps as it relates to kind of your new role.
Thank you. Thank you. Hi, everyone. So nice to see so many people. I'm Anika. I'm one of the chief residents at Jacobi Medical Center in the Bronx. I just started chief resident maybe a month to 6 weeks ago, so just settling into my new role. Very excited to be here amongst all you wonderful people who are breaking barriers to actually bring women in medicine out there, and telling people that it's okay to feel out of place and to feel that imposter syndrome. Because I think as I was watching a lot of a lot of your stuff, I feel like we just tend to suffer in silence, and we tend to feel like we're the only ones going through it. So this is such an amazing platform to know that so many people out there feel this way and support you, and that it's going to get better. And I think one of the things that I relate to the most as being a woman in medicine and now in a leadership role is trying to find that balance between being perceived as, trying to be assertive, but then not wanting to be perceived as pushy or bossy, which I think is sometimes the automatic category that women get pushed into when they try to take on a leadership role. And I'm eventually hoping to get into Pankrit, so this becomes very relevant as a code leader or something like that. So I think I spent a large part of my early years just trying to blend in with the wall, I just don't want to be seen. I'm just going to stand in the back and hope for the best. And it took a while to find my voice and to be assertive and realize that that's not being pushy, that's not affecting somebody else's growth. And I have something to contribute, and it's going to help everyone around me. So I'm trying that out now with my new role, and I guess I'll let you guys know how it goes over the year.
Love that, Anika. Thank you so much for sharing. Andrea, do you want to introduce yourself and maybe share any reflections that you have?
Hi, I am Andrea Nampa Guzman. I am a last year medical student in Lima, Peru, and I am currently doing a research internship in Roswell Park at Buffalo, New York. Well, something that really struck me, but back in Lima, Peru, I never heard about women in medicine. Actually, the first time I learned about it was in a workshop in the US. And that's when I realized, wait a minute, actually, the majority of my professors of the chairs back in Peru in my medical school are white men. And I would have never thought about, it never crossed my mind until I went to that workshop in the US. I realized, is it true? We are almost 50-50 in our medical class, but all the leadership is in men. There are not many women that are represented. So that really make me think about and reflect about the importance of representation, and that sometimes women, we tend to double guess, and the men they are more adventurous. Like sometimes the women is thinking I qualify, and the man say, no, yeah, for sure I'm gonna get it. So sometimes we don't go ahead. That's something that we should work on, especially um, in these times of change. For example, like this, my university has almost 400 years, and this is the first time we're having a female president. So I think that's a good change for the better, and that gives me hope. And also, it's not only like me knowing about it, but also like telling other people in your class or in your friend group about like, hey, I noticed this. What do you think about it? So it is a beautiful reflection. I think it is a movement that is gonna change little by little.
Thank you so much, Andrea. That was beautiful. Sukriti, Maria, and Promise, do you all want to quickly introduce yourself and we'll get to the case?
Hi everyone, I'm Sukriti. I'm part of the CP Solvers team and I'm also an internal medicine resident and I'm so excited for today's case.
Hi everyone, my name is Maria and I'll be scribing today. I'm from Guatemala and I can't wait to learn from all of these boss ladies.
Hi everyone, my name is Promise and I am a second-year medical student in the US and I have the privilege of presenting Anika's case today. I'm super honored to be presenting for the first time and I apologize in advance for any pronunciation or mistakes that I make.
No apologies needed. We are in this together. All right, should we take it away? And then maybe Anika, if you want to take the first aliquot, just sort of give us your thoughts after you hear Promise present, and I'll chime in if I have any other thoughts. Or and then Andrea, if you want to take the second aliquot, does that sound okay? Perfect.
So we have a 60-year-old female who presented after a fall at home at a neighboring hospital, and she fell onto her right foot and could not bear any weight. On arrival, the patient was altered and she could only provide a limited history. For her family, she has had multiple recent falls at home and she wasn't able to care for herself. She has significant pain because of chronic joint deformities from rheumatoid arthritis, and she's noted to be dyspneic and desaturated in the ED. She has been in shortness of breath for some time, but she doesn't have the exact time course, and she's not sure if she has fevers at home. And then for her past medical history, she has rheumatoid arthritis treated with prednisone monotherapy. She never had biologics in the past, and she is unable to see a rheumatologist. She has depression and chronic pain. And I'll pause for now.
Anika, what stands out to you from that history, and how are you starting to think about this patient?
There's quite a lot here. I think there's a lot of different ways that this can go, but I think the first step would be try to characterize the multiple problems that she's come in with, because there's 2 or 3 of them, maybe actually a little bit more than that. So to try to characterize all the multiple different problems and then see how to put that together. So at this point, like to try to synthesize, I think there is a fall, and we are unsure whether that was a syncope or a mechanical fall because we don't have a lot of history. Then there's altered mental status, and it seems to be, so there seems to be some kind of, the way I like to do it is I try to put the chronology of things in next. So this seems to be some subacute process with the multiple falls, and then something has changed recently with the current fall and the altered mental status. The whole course is complicated by rheumatoid arthritis with chronic shortness of breath and coming in with a low SAT. So I have to think about like an ILD kind of complication, but that's where I'm going with this. Altered mental status may be an infection, a syncope, or weakness that led to the fall, and possibly a complication of rheumatoid arthritis.
I love that, Anika, like tracking all of the different things that are going on. We have at least 3 big buckets of the fall, we have the dyspnea, the shortness of breath, and now the hypoxemia. And then thinking about sort of the altered mental status as what came first. And whenever I hear about falls, like it takes a lot for someone to fall. And I often find, just as you said, like sometimes there's this in the background, this kind of subacute process that's affecting the neuraxis. And then there's some sort of trigger that then, sets that person off to actually fall. And sometimes that can either be a transient loss of consciousness, but when there's no loss of consciousness, problems with, sensory abnormalities. So if someone can't see, that can lead to falls, problems with coordination, either at the cortical, subcortical, or cerebellar level. And then motor issues, so weakness, rigidity can lead to falls. And then osteoarticular problems, so things like arthritis or ligamentous injury. And we know she has a history of RA, and it sounds like she has multiple deformities already. So she's probably someone who is a substrate for falls and already at risk. And the fact that she hasn't been followed by a rheumatologist and is only on chronic prednisone suggests that without disease modifying therapies, that maybe she's had quite erosive and quite destructive RA that's kind of putting her at risk in the background. And then, just as you said, there's something that's happening in the foreground that seems to be primarily characterized by this dyspnea and the hypoxemia. And we have a whole sort of way that we think about hypoxemia, but I am a very simple-minded person. And so in my mind, it's like there's oxygen in the air, and for some reason it's not getting into the blood vessel. And so that's either because, the airway itself there's something wrong. There's something wrong with the alveolus. It's either filled with pus, bud, or water, or, there's something wrong with that space between the alveolus and the vasculature. So like interstitial fluid can increase that space and reduce the diffusion of gas from the alveolus to the vasculature, or there's something wrong with the vasculature or the vessel itself. So that could be a vasculitis, particularly in someone who has a history of RA. Vasculitis is on the differential. That could be because there's a PE. Someone with a history of RA is also prothrombotic, and so could be at risk for having a PE as well. And so lots of different things that are at play here. And I think the fact that she is hypoxemic helps us localize to the lung parenchyma itself. Certainly there could be an extra parenchymal or extra pulmonary shunt, like an intracardiac shunt, but that seems potentially a little bit less likely. And there are a number of ways that RA manifests in the lungs that I'm sure we will get into, but excellent discussion, and I'm excited to see where this goes.
Yeah, thanks for the great discussion. So for social history, she has a smoking history of 2 packs per day for 40 years. She doesn't use alcohol or drugs. She lives alone and is starting to rely more on neighbors' help because of her falls. And she's not sexually active, no recent travels, and no sick contacts. And then in terms of her medication, she's currently taking oxycodone, 10 milligrams 4 times a day as needed, amitriptyline, 50 milligrams nightly, prednisone, 5 milligrams daily, Dulcolax, cyclobeneprin, 5 milligrams daily, and then citalopram, 10 milligrams daily. And I'll pause for now.
And then promise, I heard, so there was oxycodone, prednisone, amitriptyline, cyclobenzaprine, and then was there something else?
Dulcolax.
Dulcolax, okay.
Mm-hmm. And then also citalopram.
What was that last one?
Citalopram.
Oh, citalopram, great. So an antidepressant. Is that the end of the second aliquot?
Yes, sorry.
No, that's super helpful. Thank you so much, Thomas. This has been excellent. Andrea, what's standing out to you from this additional information?
The fact that she's taking amitriptyline and benzapines, like normally those are advised again, advice against in elderly population. So maybe this could be the cause of the falls, that maybe she's having some fog and that's why she's falling. It will be nice that to see the cholic gas, oxycodone, who given, so I would think that the primary care physician gave her these medications, but didn't give her a referral to rheumatology is a little bit concerning. And the fact that she lives alone makes me think that she may not live in a safe space. So thinking about the fall, it could be related to the neuroaxis, something that is wrong with her, or maybe that she has other factors. For example, she lives in a house that is not secure for a person of her age. So it could be that because she has rheumatoid arthritis, she can be prone to an infection, and that may be making her condition lower. It can be a secondary cause of this medication that is normally not prescribed to elderly because of the secondary effects. It could also be that she and trying to connect this with the dyspnea, maybe she has some kind of Kaplan syndrome or any interstitial disease that it results from the rheumatoid arthritis that is making her out of breath and getting an infection over it. This is making her more prone to falls. And the fact that she hasn't seen a rheumatologist in a while makes me feel like this person should be seen by a social worker. Like we need to make sure that this patient has a safe environment, because it's very unlikely that she's going to thrive in the environment she's living right now. Also, the fact that she smoked for 40 years can also cause, apart from the rheumatoid arthritis, that the fact that she smoked for 40 years can also damage her lungs.
Andrea, that's such a great point, particularly sort of thinking about the person and their context. And oftentimes when we see people in clinic or in the hospital, it's hard to sort of imagine what that person's world actually looks like. And you're making a great point that this seems really unsafe. And it seems like she's been really suffering at home, and that her home may not be a safe place for her right now or anymore. So really astute, and I essentially have nothing to add. I agree, she's on multiple medications that can make her altered, that could lead to these falls. And so definitely meds can contribute to altered mental status and to falls. And particularly if there's some other acute process going on, having these meds on board as well can sort of exacerbate that presentation or cause her to be more altered than perhaps she would have been. For example, if she has an infection and then has an AKI and isn't able to clear these meds as effectively, they could build up in a way that could cause altered mental status. But otherwise, I have nothing else to add. I totally agree. I'm really worried about a process in her lungs potentially related to the RA, such as ILD. And so we'll be looking forward to getting an exam and some data.
Okay, so for vitals, her temperature was 36.4, and then her heart rate, I think it was taken twice, so it was 117 and then 101. And then her respiratory rate was 20, her blood pressure was 110/56, and her SpO2 dropped to 80s, and then now with 4 liters O2 saturating, she's in her mid-90s. For the physical exam, she appears thin and then older than her stated age. She's disheveled, she looks disheveled, and she's alert but only oriented to the person. And then she has small contusion above her left eyebrow, a traumatic head, and sclera and pterygium. And then for her heart, the rhythm is regular but is tachycardic. And then normal S1 and S2, no appreciable murmurs. For lungs, there's mildly increased workup breath on 4 liters and with diminished breath sounds and diffuse expiratory wheezes. And then for her abdomen, it felt soft, non-tender, and non-distended. Her extremities were warm and well perfused, but she has bilateral hands and feet with notable swan neck deformities with swollen MCP, DIPs, and no active erythema. And then 2+ bilateral lower extremity pitting edema with the right side more than the left side of her leg. And then for skin, she has ulcer on the right lower abdomen with surrounding erythema, ulcer on the left distal arm that has jagged borders surrounding erythema, multiple ecchymosis over the right side of her body, including her face, her arm, and her leg, which is consistent with her fall. And I'll pause for now.
That was excellent, Promise. One question that I had, so it sounds like she has 2+ lower extremity edema, is that right? And then has an ulcer in the abdomen. And then were there any other ulcers?
Yeah, so the ulcer in the right lower abdomen has surrounding erythema, and then the ulcer on the left distal arm has jagged borders with surrounding erythema, and then multiple echymoses.
Great. Anika, what do you think? This is quite the exam.
Yeah, there's a lot happening over here. I'm still kind of struggling to tie it all together, so I'm just gonna put some thoughts out there, and I guess as things go along, we'll see how it fits together. So first things to notice would be that she is tachycardic. She is not hypotensive, but there is a slightly more than normal pulse pressure there, which we'll see if that ties into anything later. She is hypoxic and in respiratory distress with, it does seem like our initial thought of something is localized in the lungs there. It seems to be one of the primary processes with increased work of breathing and diminished breath sounds. I am trying to put something together with the ulcers in the abdomen with surrounding erythema, and I think the main thing that comes to mind right now is some kind of a vasculitis picture with it seems to be a multi-organ thing. So vasculitis generally tends to fit a multi-organ presentation. So we have lungs, we have the skin that is affected, and in a patient who has rheumatoid arthritis. 2+ bilateral lower extremity edema. At this point, that would be a slightly larger differential. So not very sure what to make of that. We would have to get a little bit, some more information that could be coming from anywhere right now. So I think at this point, we still have infection on our differential. We still have, we can probably put vasculitis on the differential. I think that's all I have for now.
Anika, that sentiment of there's so much going on is very much resonating with me. And it seems like, I was expecting that the center of gravity of the exam would be on the hypoxia, which we certainly see here with the respiratory distress. But then there's this whole other layer with the ulcers and, the bruising. And so sort of thinking about the pulmonary exam, it seems like definitely there's workup breathing, and I'd be thinking in the back of my mind as we're sort of sending off our diagnostics, is this person going to start to tire out? And thinking about management as well as we're getting these diagnostics. So making sure this person's protecting their airway and not tiring out. Otherwise, we may need to intubate this person. But then sort of tucking back in the background, thinking about, well, this person does have evidence of volume overload with the 2+ pitting edema. we haven't really heard whether the JVP is elevated, but are we getting signal for potentially evidence of total body volume overload? And in the setting of rheumatoid arthritis, we know that rheumatoid arthritis can be associated with pulmonary hypertension and RV and subsequent RV failure. So, and that can be quite difficult to manage, and people can get very sick very quickly. So that's kind of another thing that is sort of in the back of my mind. And with the expiratory wheeze, is that pulmonary edema and a cardiac wheeze, or is the expiratory wheeze actually because she has a 40-pack-year smoking history and has some underlying COPD and potentially has either a COPD exacerbation or some underlying reactive airway disease to whatever else is going on? And then I think just moving on to, just like you said, Anika, with the ulcers, it does raise my suspicion for potentially some sort of, I will say, diffuse process, like the fact that it's on the abdomen and in the arm, like makes me, whenever I see like a rash or an ulcer, I'm always like, well, is this an inside job or an outside job? And when they show up on multiple sort of like unrelated locations like that, I often think like, well, maybe this is more of an inside job. And so could it be sort of a vasculitis? We know RA is associated with a cutaneous vasculitis and can also involve the lungs and cause DAH. I think the differential, just like you said, Anika, continues to be broad. So could this be something that's infectious? She is immunocompromised and could have a disseminated infection that actually what we're seeing is the sequelae of that. So for example, this isn't quite classic, but like endocarditis, you could get embolic phenomena and get distal ulcerating or distal nodules or ulcers as well. And then we know that she's chronically on prednisone, and so she may be someone who is immunosuppressed. We didn't really get the dose that she's on, but it sounds like she's at least been on it for a very long time. And so all of our atypical infections are at play, are endemic mycoses that can have skin manifestations as well. And so that would be one thing that I maybe want to call derm and have that biopsied. And then just thinking about maybe the multiple ecchymoses are just from the fall and from bruising, but wanting to make sure that there's no coagulopathy going on as well. So I think in summary, totally agree. There's so much going on. We know that there's something going on in the lung parenchyma, also worried about potentially the cardiac function. And then with these distal ulcers, could there be some sort of infectious etiology or non-infectious etiologies? And all of those are at play.
I love this comprehensive discussion. So for labs, for her white blood cell count is 0.8, and then red blood cells is 2.76. Hemoglobin is 7. HCT is 22.4, and then her MCV is normal. MCH is 25.3, and MCHC is 31.1. RDW is 18.7, her platelet count is 186, and then her ANC is 0.1, ALC is 0.6, and then her sodium is 133, and her chloride is 96, BUN is 26, creatinine is 0.87, and then her BUN to creatinine ratio is 30. And then abdomen is 1.3, calcium is 7.7, total bilirubin is 1.4, AST is 330, and then INR is 1.38, APT is 0.2, lactate is 2, pro-BNP is 5,300. I also have other values, so if you want that, you can let me know. And I'll pause. Or also, she's COVID-19 negative, and I'll pause here.
Maria, did you have any clarifications that you wanted to make to the labs?
I'm not sure, but like if I'm missing something, you can just write it in the chat and I'll add it.
Awesome. Great. And then do we have any serologies promise of how like the RA diagnosis was made, like a rheumatoid factor or a CCP?
Yes, but I will disclose that in the next outlook.
Okay, perfect. So maybe we'll pause there. Andrea, take us away.
Well, so we have a patient that is in Pasitopenia, so we can think that we think about the blood marrow. We think like what can cause the Pasitopenia. It can be like an inflammatory cause. So when we think of rheumatoid arthritis, it can be like, for example, if this patient was in medication, methotrexate tends to cause Pasitopenia, but because she is not, I will think about, I don't know, how do you say this? Hematophagocytic syndrome. Or I would think in something of that nature. Also, the fact that she has been doing all, she has this Pasitopenia, I would think that she is in big risk to have an infections, a very severe infection. And because of that, I would feel like in maybe some kind of fungus that may be in the skin that is causing these ulcers, but it can also be the vasculitis. There is rheumatoid vasculitis, and normally this kind of disease is a sign that of bad prognosis. So it could be a rheumatoid vasculitis, or it can be like an infection. And again, I don't see which one could it be. It's still a little bit, I'm still a little bit unsure about it. But this patient definitely needs like to be seen by hematology.
I absolutely agree with you. I am worried about this patient and thinking about, well, how do these cytopenias fit in? And whenever I think about my approach to cytopenias in general is just, are we not making them? Are we destroying them? Or are they sort of sequestered somewhere, usually in the spleen? And usually you would see some splenomegaly either on imaging or in the on exam. And the reason that I asked, this was just as an aside, asked about the serologies for rheumatoid factor and for CCP to figure out how the diagnosis was made, is just that often people can get these rheumatologic diagnoses, but there's a lot of overlap, and that can sort of influence how we think about both treatment and what they are at risk for, things like pulmonary hypertension, et cetera. So that as an aside, I agree with you. I think the neutropenia is really concerning and puts her at risk for all sorts of atypical infections. And particularly with the hypoxia, thinking about, like our solid organ transplant patients who are neutropenic and come in with pulmonary infections can get things like organizing pneumonias. They can get nocardia, classically in a solid organ transplant patient, aspergillus. And so I'm worried about all of these different kinds of infections. So I think the way that these labs change kind of how I'm thinking about this patient is our priority is to rule out infection number 1, 2, and 3. And so I think this patient is heading toward the tube of truth so we can get a better look at the lung parenchyma, plus minus potentially a bronchoscopy to actually take a look and see if we can get any samples to make a diagnosis. And then I think reassuringly, the platelets are normal here. And so with usually the anemia and thrombocytopenia makes me think more of a destructive process. Often this isn't as like clear, but often the leukopenia anemia process often is more of a bone marrow suppression process, but there could be a secondary issue here where we know that she has multiple ecchymoses. And so I would want to make sure that she's not acutely bleeding. And we're not given here what her baseline hemoglobin is, but the fact that she's tachycardic, maybe the tachycardia is just from the hypoxia, but maybe she's also bleeding. So that's going to be another thing that I'm sort of holding in the back of my mind. And then the pro BNP being 5,000, I think we mentioned that she was volume overloaded on exam, and I think we're seeing sequelae of that here. And so we'll probably want to get more diagnostics, including a TTE to look at her systolic function, but then also her RV function as well, including a PASP, a pulmonary arterial systolic pressure, to get a sense of if we're seeing sequelae or evidence of pulmonary hypertension. And so I think we would probably be covering this patient broadly with broad spectrum antibiotics, including potentially empiric fungal coverage. We'd be sending her to the tube of truth to get a look at her lung parenchyma, and then maybe we would even be setting her up for a bronchoscopy. And a one management pearl is that it's actually not that safe to do bronchoscopy once someone is on sort of 6 or more liters. And so now is kind of the right window to think about potentially getting a little bit more data. So I'll pause there. Any other thoughts, Anika?
Yeah, I think what you said is absolutely right. Like, I think that the priorities change so much after looking at these labs. Like a white count of 0.8 with the ANC being as low it is, it definitely does make me nervous as well. The first thing would be, you know how in the physical exam we're talking about, is this coming from an infection or is something else going on? But I think after looking at these labs, the first priority now shifts to covering an infection if there is one, and then trying to figure out more about why that's happening. I think given the neutropenia, one of the other diagnoses that maybe ties in with the ulcers, maybe not the lung all that much, but is pyoderma gangrenosum, which can cause all these different ulcers, and they look pretty bad. And I think given that the risk for infections is high, that would be one of the differentials. And then one of the other things to also keep in mind, which I've been burnt by before, so I'm just going to bring that up, is in this patient, and we definitely prioritize infection, but I do think common things are also common, and this patient has been on prednisone for a very long time. So we have to like put in other like PCP, I know doesn't really go with neutropenia, but it's still there. It's still high up on the differential so far. I think that's all I have. Yeah.
Such great points, Anika. Thank you.
Okay, so the patient has HIV negative and then Hep B, C negative, B12, folic acid, copper, zinc are within normal limits, and then LDH is also within normal limits. Her RF is greater than 1,200, CCP is greater than 340, ANA is 1 to 160 in spectral pattern, double-stranded DNA negative, ENA negative, C3 is 65, C4 is 9.7, SPEP is not monoclonal, cryoglobulins negative. And then her CRP is 272, her ESR is 106. And then she also did a peripheral smear, so her platelets were decreased. Erythroid, she has normal cytic anemia without significant anesthesiocytosis. And then leukopenia with neutropenia and lymphopenia, negative for blast, dysplastic granulocytes, morphologically abnormal lymphoid cells, and circulating plasma cells. And then for her CT chest, there's right upper lobe consolidation with extensive air bronchograms, and then air fluid in the pleural space. And then no CT evidence of pulmonary embolus. There is underlying ephysematous changes, and the CT leg showed tibial plateau fracture, TTE is normal, EF without valvular abnormalities. And I'll pause for now.
Anika, what do you think about these labs?
I think it was a really good idea to check cryoglobulins. I don't think that actually came to mind the first time we were discussing, but cryoglobulinemia is a big one here. So that's good. The LDH being normal is slightly like it's pointing away from certain things, but let's see, HIV being negative is very helpful. I don't know, is there like some kind of, a right upper lobe thing on the CT? It's a right upper lobe consolidation, right? Yeah. And air fluids in the pleural space. So this is some kind of, it's a consolidation with potentially an emphyma. I don't know if we're missing some kind of atypical fungi, or, you know, the less likely stuff like nocardia. Some, like, it's not coming together very well. Like the right upper lobe consolidation is throwing me off a little bit. I definitely agree with what you said earlier. I think we are going towards, you know, close to a bronch route. And there's, I think we're missing like either a fungal infection or something else there. Yeah.
Yeah, this is really interesting. And Promise, was there any sort of hint of like cavitation, or is it just like a large consolidation in the right upper lobe?
On the K's, it
I
didn't
think
say that.
I just got a message from Anne Marie that it does seem like it was a cavitary lesion. Anne Marie, is that right?
Yeah.
She just sent me a direct message.
Do you
Okay.
want to see a picture?
Yeah.
Oh, I actually don't think I can share my
that's okay.
screen.
That's okay. It's really helpful to sort of hear that it is cavitating. Anika, does that change kind of how you're thinking about it?
Sorry, I was talking on mute. So it's a cavitary upper lobe. It's a cavitary upper lobe lesion, right? With the potential, does that look like it's an emphyma with that air fluid level thing? Oh, okay.
Oh yeah, that's legit.
Yeah. Okay. It does add, like, maybe okay, so if it's a cavitary lesion, it could be, like I said, first, common things being common in an immunocompromised non-neutropenic patient, could be your regular, you know, bacteria. It could be atypical mycobacteria. That's another thing that I'm thinking about. Someone who's been taking prednisone for a very long time, maybe one of those is flaring up. Still, rheumatoid vasculitis is a possibility. Like, it's still hard to I know we're looking for an infection, and you are 100% right. It is 1, 2, and 3 on the differential. But is this all coming from rheumatoid arthritis? Are these all complications of without an infection? Are we just seeing lung manifestations of rheumatoid arthritis? Sorry, my phone is, I hope that's not disturbing anyone. I'm just going to put that on silent. I should have done that earlier. Sorry. Yeah, so I think rheumatoid vasculitis and complications of rheumatoid arthritis is still possible. Putting it together, and I think this came up in the chat a little bit with the leukopenia and the neutropenia and rheumatoid arthritis, there is that, it's much rarer, but there is the syndrome of Felty syndrome, but I don't know if there's actually splenomegaly here. I believe that is very important to this. So I'm not sure if the CT chest managed to capture a bit of the spleen to give us that information. But I think now I'm thinking a little bit more of mycobacterium and atypical organisms as well with vasculitis.
I totally agree. And Promise, how many more aliquots are there?
So there's 2 more, and then there's the final diagnosis. And
Okay,
if you want me to speed up, I can just present one.
Okay. I will just point us to the CP Solvers has a great lung cavity schema that I always reference. And I totally agree with you. My money is on some sort of fungal infection potentially, or that this is autoimmune in nature.
Okay, so then for the next aliquot, the CT abdomen showed that she has splenomegaly, 15.6 centimeters, and then her respiratory pathogen panel is negative, quantiferon gold is negative, Fungital is 78, fungal antibodies negative, crypto negative, histourine antigen negative, and unable to get a sputum for TB testing. She declined bronchoscopy and skin biopsy.
Yes, Andrea, what is standing out to you here? What do you think about this CT abdomen?
Yeah, that's a common first sight. Like that's Felty syndrome, that is like a big spleen, rheumatoid arthritis, decreased white blood cell. Well, we are thinking that this is an infection. I agree with and apart from that, well, we have that she has a fracture. Well, that is from the fall, and yeah, like I think that I agree with Anika that the lesions of the abdomen can be also vasculitis. Yeah, it's a classic file triad.
I love it. This is so classic. It's so fun. Yes, exactly as you said. And, you know, with the neutropenia, she, just as we said, is at risk for all of the typical bacterial infections and all of the atypical infections as well. And then a lot of these patients are also at risk for malignancies, particularly lymphomas as well, as one other pearl, but this is very classic Felty's triad and may account for some of her cytopenias like we talked about. Anika, any other thoughts?
No, I don't know. I think Felty syndrome now with the splenomegaly, I think it's tying together. I don't know if that, I have never actually looked at this, whether it causes skin ulcers, but probably does. It seems like it would be part of the process, and I'm not sure about that at all. But that initially it was a little lower down on the differential, but now the way it's tying together, it's coming a little bit higher up. And yeah, I agree with Andrea. The fracture is definitely coming from the fall. So I don't think that has to tie into this whole picture.
And I do think that you can get extra-articular manifestations of the ulcers, so that I think would fit.
Okay.
Okay, so a bone marrow biopsy was done, and we found that there's hypercellular bone marrow, 90% of trilineage hematopoiesis, about 8% T large granular lymphocytes identified by flow cytometric analysis, and then the TRG gene rearrangement is positive, the cytology is normal. And I will pause before the final diagnosis.
So sorry, I don't know if I caught the whole thing. So it's a hypercellular marrow and cytology normal. T cell gamma receptor rearrangement. Okay. So I'm just going to start with the hypercellular part. I think this goes a little bit close to, like when I'm looking at these kind of pancytopenias, like you were saying, is it either coming from not enough being produced to it being produced and then it is being destroyed somewhere else? So I think the hypercellular marrow with splenomegaly is pointing towards the marrow is working okay, it is being produced, but it is being destroyed somewhere else, likely with the rest of the labs putting it together. This is not hemolysis, likely being like destroyed in the spleen. I'm just trying to 8% large T granular lymphocytes in the cytometric analysis, cytology positive. Is that pointing towards like some kind of a lymphoma, the T cell lymphoma there? So yeah, that is, like you were saying, that they are more prone to malignancy. So I think this one is pointing more towards a T-cell lymphoma. And okay, backtracking a little bit on what I said then, that maybe in this case, it is probably being consumed, but also it is possible sometimes that the marrow is being like, in that it's hypercellular, but it's still destruction of the original marrow architecture, which could cause all of this, like all the pancytopenias. Infiltrated, yes, thank you. That's the word.
Yeah, I agree. I think I am also sort of wondering kind of where the level of the pathology is. I'm pretty sure in Felty syndrome, you can see a hyperplastic marrow that you basically get ineffective erythropoiesis and you're releasing all of these like immature cells that aren't ready, is my vague understanding. And then either they're immature and they get destroyed because they weren't ready to begin with, and then they also get sequestered in the spleen. Someone who is a hem-onc person, please add to our knowledge here. But this does seem consistent. I'm not sure what to make of the specific T-cell receptor rearrangement. I imagine that probably also leads to kind of like a cascade of either ineffectively or incorrectly produced cell lines. So that's kind of what comes to mind and seems consistent with the rest of the presentation, but I'm sure there's sort of a unifying syndrome for what's going on. And then, yeah, I still think, you know, what's in the lung could be RA, infection, malignancy, really anything else. And then the other constellation of other things going on, I think is still consistent with Felty syndrome secondary to RA. Andrea, do you have anything to add?
Well, I know that the fungal antibodies came negative, but they are not. They are not. They are sensible, but I think it's very limited. It's not that they will rule out the infection. So we can still think about fungal infection, but a little bit less. Yeah, and I agree with both of you. Like this sounds like a T lymphoma, T-cell lymphoma.
Okay, so for the final diagnosis, the patient was diagnosed with Felty syndrome, like everyone talked about. And I really like how Anika put rheumatoid vasculitis in her back pocket, because it was Felty syndrome with possible rheumatoid vasculitis complicated by necrotizing cavitary pneumonia, likely secondary to aspiration. And then the decision was to treat with methotrexate, which would treat both Felties and large granular lymphocytic leukemia. But the notes here says that with LGL leukemia, there's usually a lymphocytosis, but her smear was normal.
Wow, what an amazing case. Learned so much. Anika, Andrea, any reflections on the case?
I think this was an amazing case right from the beginning. Like now that I'm looking at all the information that is on the slide, in each little box there is just so much happening. This is a very nice case to have an organized thought process, because there's just so many details. It's so easy to get lost in the details or try to put two things together and then a separate set of three things together. And I think having an organized thought process like you were doing, where you know, trying to think through the whole thing to put it all together to one thing, one diagnosis that fits almost everything that's going on. I think this is the ideal case to learn that.
Yeah, it was a roller coaster. We started with something and we ended up with Felty syndrome. It's like it's tough for step one, but it's not very common. And first time see a Felty syndrome in real life. And yeah, especially with a patient that is immunosuppressed, like you tend to think more in infections. And I was like, yeah, it could still be an infection. And the fact that it was like rheumatoid vasculitis, that is not very common. And like, it really makes you think about every little thing. So I really enjoyed this case. Thank you, promise.
This was awesome. I see Sukriti has a question in the chat around the lower extremity edema and the pro-BNP. I wonder if there's sort of another process going on that maybe needs further workup, like a right heart cath or whatever, to get a better sense of what's going on. And then the sort of right upper lobe, I don't think of as usually being where aspiration goes. I usually think about when you aspirate, it sort of ends up in the dependent areas. But I suppose like if you aspirate when you're laying down, maybe you could get to the I'm not quite sure how that fits, but so much great learning in this case, and I learned so much with all of you, from all of you all, and I'm sure there are a million pearls in the chat that I can't wait to scroll through and learn from. Promise or Anne-Marie, any other teaching points or things that you wanted to add in?
So I have some teaching points, just to be really quick. So Felty syndrome, like everyone said, there's like the triad with rheumatoid arthritis, neutropenias, and splenomegaly. And the mnemonic I found is called I felt Santa's foot. So sometimes you can have anemia and also thrombocytopenia. And then it's unknown cause is more common in women between 50 to 70 years old, Caucasian population usually. And then I think like there are a couple of possible causes of neutropenia, including like autoantibodies to deaminated histones, like GCSF autoantibodies, cytotoxic T lymphocytes. So when I was reading the case, I feel like the T lymphocytes in the bone marrow was because of that leads to the neutropenia. And then it says that bone marrow cellularity can show myeloid hyperplasia with excessive immature forms that can be prematurely released into the bloodstream. So that fits the smear results. And then I also found that for fever, usually if they have fever, that means an infection. So like you guys discussed, and if there's no underlying infection, but there's a fever, it could mean rheumatoid vasculitis or fulminant polyarticular synovitis. And then there are extra articular symptoms, including ulcers, brown pigmentation of the skin, which would clue into vasculitis, necrotizing skin lesions. And then in the lab findings, usually you have positive ANA, positive ANCA, ESR, CRP would be elevated, RF positive, and CCP positive. And then for RA and Felty, that would lead to an increased risk of lymphoma. So you want to check their lymph nodes. And usually that would lead to non-Hodgkin's lymphoma. And I think there are two pivotal points of this case when I was reading it. I think one is like once we found out the RF, CCP, and ANA positive and a negative ENA, that kind of like brings us into the autoimmune causes of the patient's like leukemia, leukopenia, and like frequent falls in RA. And then the other thing is like seeing the CT chest, we know that there's something wrong with the lung. So there's like two different things to think about. And then the smear results kind of just show that it would either be Felty or LGL leukemia. And then the bone marrow biopsy pretty much put it into the Felty's box. So those are the pivotal points of the case that I saw. Yeah, and I'll leave it to Sukriti to summarize that.
Thanks, Promise. What an awesome discussion. I think Promise covered everything about Felties, but maybe I can just walk everybody through how we thought about this case. And so to summarize this case, went through three sort of rounds. The first was investigating the symptom. The second was collecting clues from the physical exam, the past medical history, and then essentially framing a hypothesis using some additional data that we got from the labs and imaging. And so as Anika and Andrea started us off, we thought about the falls essentially as what do we need to walk? So you think about what's going in, the input, and then the output. So you need vision and proprioception, and then the output is you need effective coordination, neuromuscular, basically your neuromuscular physiology should work, and then the osteoarticular part of walking. And then thinking about hypoxemia with this fall, why is oxygen in the atmosphere not reaching the lung? And basically you walk through the anatomy. So thinking about the airway, the alveoli, the interstitial space, and vascular. Classically, we think of hypoxemia localizing to the lung parenchyma. So you think about what's in the alveoli. Is it pus? Is it blood? Is it water? And what was really pivotal to this case was layering on the foreground, which was the fall and the hypoxemia, onto the background, which was the rheumatoid arthritis, which Anika and Andrea picked up very early on. And something that we learned from Smita was to look beyond the disease process at play, which was rheumatoid arthritis, and consider what is the severity of the disease, what is the clinical course that it has taken, and what therapy is the patient on for the disease. So just consider disease association. Here we came up with a few, thinking about RA with pulmonary hypertension, with vasculitis, and then with Felties ultimately. And then with medication, we noted that this patient wasn't on biologics and how that was going to affect the clinical course, as well as any immunosuppressants that this patient was on that would predispose them to an increased risk of infection. And so essentially, as we progressed into the case, we got this data in the form of her physical exam, which was, very voluminous. And there were so many nuances to every positive finding that we got, thinking about like pitting edema as, essentially equating it to volume overload. And then as Rabi and the CP Solvers team talks about, volume overload is essentially three things: your cardiac, your liver, and kidney. And then thinking about this in the context of RA, we also thought about pulmonary hypertension, and then the need for a TTE and PSAP to further work up this patient. And then thinking about the expiratory wheeze, we were thinking, was this because of a cardiac pathology, and would this support the pitting edema hypothesis that we have, or was it secondary to a COPD given her smoking history? And essentially something that was very interesting that we discussed was these ulcers, both in the abdomen and then in the distal arm. And something that I learned from Smita today was, when you think about pathology in different sites, think about an inside job. And what do we mean by an inside job? We mean either inside the blood or as part of the blood vessel, versus an outside job, which would, localize to an organ system or to an organ. And so here we thought about RA with a vasculitis, which could lead to a DAH. And really, one of the pivot points of this case was the bicytopenia that we saw. And we basically broke this down into buckets, which was increased destruction, bone marrow suppression, and sequestration. But given that it was like an anemia and a leukopenia versus, a thrombocytopenia, we thought more about like an increased destruction or bone marrow suppression at first. And then just expanding our knowledge of, what organisms would this person be predisposed to given her neutropenia. So thinking about organizing pneumonias, nocardia, and aspergillus. And then in terms of thinking about the anemia, we basically looked for clues of, whether she was bleeding, whether there was an elevated LDH or a decreased haptoglobin that could, point us towards like a hemolysis. And then how was her bone marrow? Was it working? Was it not working? And when we began framing our hypothesis, we framed this case as essentially a cavitary lung lesion with splenomegaly, Cytopenia, and of course our history of rheumatoid arthritis. And given the illness script, this fit perfectly into Felty's syndrome. But what was also super important in this case was not only diagnosing this patient, but also thinking ahead. What is this patient, predisposed to? What is the risk in this patient? And you think of a risk for a lymphoma and for infection with atypical organisms, especially like fungus and virus infections. And I think everyone did like an amazing job discussing. I really learned a lot from everyone, so I really enjoyed this session.
Sukriti, that was such a masterful summary of our case and our discussion. Thank you everyone for joining for this month's WDX, and look out for our next one. Thank you, Anika and Andrea, for choosing to join us in the lukewarm seat, and for Promise for presenting the case. Thank you all so much. It's been so fun learning from you. See you soon.